All right, so my name is Jeffries. I'm a physical therapist, and I'm going to talk about concussion management of a D1 collegiate football athlete that I was working with. Let me see if I can. All right, I'm going to start a timer now. So I completed a residency program in San Antonio last year at a college program where I was able to work with D1 athletes. I worked primarily with football while I was out there. The purpose of my presentation is to highlight the course of care for an individual who had post-concussive syndrome, and that's defined as having concussion-like symptoms that persist longer than expected. It's a very general definition, but we can expect them to resolve within 2 weeks of time or so on average. That's an age-dependent factor. The younger you are, the longer your prognosis is. So a concussion is a complex physiological and functional injury involving a chemical cascade of events following violent impact or strong rotational forces to the head. So it doesn't necessarily require head impact itself. It could be from things such as whiplash. Something unique about concussion rehab is the variety of symptoms that someone may present with and the different body systems that may be involved. It's been recommended by experts that we should classify our patients into profiles based on what body system we think is more involved. And then from there, that can help guide our interventions. Those suffering from a concussion may have a wide variety of symptoms, such as a headache, dizziness, light sensitivity, noise sensitivity, memory deficits, balance impairments, and more. Due to the wide range of symptoms, we want to use an interdisciplinary approach. We need to know our scope as a physical therapist and when we need to refer them out. So I want to now further dive into a case regarding a 20-year-old male offensive lineman who suffered a concussion after receiving a lateral blow to his helmet. He was referred to PT 3 weeks after onset, so that's already going past the 2 weeks that we expect him to resolve in. Whenever a physical therapist is treating the neck, especially after a trauma, we're going to want to rule out any more sinister pathology. So we have to determine if they're appropriate for physical therapy by doing cervical instability testing and vertebral artery insufficiency testing. Cervical instability may result in central nerve dysfunction, which is also known as myelopathy. There could be cranial nerve neuropathy. There may be brainstem compression or vertebral artery injury. And then vertebral artery injury, that can directly affect the blood flow to the brain. Your two vertebral arteries join together and form the basilar artery. And that's going to give you the nutrients that you need to your brainstem, which the brainstem itself is responsible for many of the autonomic functions, such as breathing and our heart rate. Primary red flags I'm looking for when assessing the neck are 5 Ds and 3 Ns. It's just an acronym that we use. We're looking for dizziness, trouble swallowing, also known as dysphagia, dysarthria, which is trouble speaking, drop attacks, double vision, numbness and tingling, rapid eye movements, and nausea. If those are present, then we need to refer them out to a physician and have them cleared before they return back to physical therapy. So the reason we go into depth about the cervical spine is that that can serve as a source of dizziness itself and headaches. And as I mentioned before, these are some of the more common symptoms that are associated with a concussion. So there's different receptors in the spine, especially the upper cervical spine, that play a role in knowing where we are in space. That's called proprioception. And they provide sensory information to our central nervous system. Our central nervous system then processes all this sensory information so that we know where we are in space, and it activates different muscles to respond to external forces. So there's some different suboccipital muscles. There's the rectus capitis posterior major and minor, obliquus capitis superior and inferior. They have a higher spindle density and other distinct morphological characteristics, such as their composition of fast and slow fibers. And they're important for controlling movement and posture, providing proprioceptive information to control the position and movement of the head and coordinate the eyes and head movements. So the oblique muscles handle more proprioceptive input than the recti muscles. They think the recti muscles serve more as holding our head up against gravity. The rectus capitis posterior minor and obliquus capitis superior have greater cross-sectional areas. So they are better served as anti-gravity agonist muscles of the head as compared to the rectus capitis posterior major and obliquus capitis inferior. It's a mouthful for sure with these muscles. All right, cervical proprioception can be assessed using a test called joint position error testing. And what you do, and this is what I did with my patient, is you have them wear a laser that's on like a headband and that's pointing straight forward. You have them find what they feel like is their natural neutral position. And then you're going to set up a bullseye target aligned with that neutral position. You have them close their eyes, they turn their head to the side, and they try to get back to where they started from. And that's testing their proprioceptive abilities. Another test is using a blood pressure cuff. You have them lay on their back, you put the blood pressure cuff inflated to 20 millimeters of mercury, and then you have them try to increase it up to 22 millimeters, hold it for a specified duration. And that's another way that you can test their cervical muscular endurance as well as the proprioception. Okay, and then so another question that people ask, myself included, was, well, how do your eyes and your inner ear balance system work together? So we have an innate reflex known as the vestibular-ocular reflex, and that helps us remain stable and balanced while we engage in normal activities throughout our day. That helps trigger our eyes, creating an eye movement opposite to that of our head. So when I look to my left, my eyes are staying focused on the target in front of me. That's vestibular-ocular reflex. It's more from a hunting and gathering type of reflex, but we use it in our everyday life. That's going to help you keep your eye focused on a target so that your retina can allow the light to come in and produce the image of that target without it becoming blurry. So it helps us track objects, like I was saying. Vestibular motion sensors include, within our ears, we have semicircular canals as well as otolith organs. The otolith organs are saccule and utricle, and that's sensitive to linear acceleration. So if you're going quickly in a car and your head's remaining in a constant position, you can feel that change of position using those sensors. But then there's also the semicircular canals, and that's more when you're actually moving your head. So when you're moving your head, you have hair cells that are embedded in a fluid and gelatinous structure called the ampulla, and there's fluid inside of our ears, and it kind of sloshes around when you move your head. And so the canal on the side of the head turn that you're moving towards. So if I turn my head to the left, my left canal is going to be activated. And then on the other side, it's going to be inhibited. And the rate at which it does that is based on the speed of the movement. Anyway, all the information that you gather from where you are in space is sent via cranial nerve 8, which is the vestibular cochlear nerve, to our brain. And then that is processed by our central nervous system. And that has the ability to control our ocular muscles and tell them what they need to do. All this happens in milliseconds, right? You just turn your head left and your eyes stay focused on the target. Unfortunately, that's not always the case in patients that are post-concussion. So then there's also vestibular spinal reflex. So some of that vestibular input can help maintain our upright posture so they don't fall over. So if you have a disrupted vestibular ocular reflex, you can get something called oscillopsia, or you can have nystagmus. Oscillopsia is blurry vision when your head is in motion because the objects are going to seem like they're bouncing around and you're not able to stay focused on that target. Nystagmus may also cause blur because if I turn my head one way, it's going to beat back. So your eyes are going to beat out to the side. So that's going to make it hard for you to focus on the target if your eyes are moving in a rapid fashion and involuntary rapid fashion. So ways that we can assess your vestibular ocular reflex is a test called the head impulse test. And what you do is you have the patient focus on your nose in front of you. They're in front of me and I'm supporting their head. And then I turn their head rapidly like this, and they should be able to keep their eyes focused on my nose. If not, then that suggests that there might be some vestibular hypofunction. Other testing may include vestibular-ocular motion sensitivity screening. And with that, I'm looking at things like smooth pursuit. So I'm looking at their ocular function, saccades. So that's having them go rapidly between two targets very quickly, up and down as well. That's more testing their cerebellar function because that's coordination. They may overshoot, they may undershoot, they may be slow in their movement. So we're looking at central involvement with those kinds of things, trying to rule out anything more serious again. There's convergence. So you have them focus on a target, bring it in closer to their nose and go to the point at which it's no longer in focus. Both of your eyes should move together. If you look to the left or to the right, both of your eyes are moving at the same rate. But again, that might not be the case in someone that's post-concussion. Another test is dynamic visual acuity. So for that, you read an eye chart, and then whatever level they're able to get to, I'm going to retest them while they're moving their head rapidly side to side at a specified beat. And you want them to score within 2 rows of the level that they were able to before. If not, it might suggest that there's some vestibular-ocular reflex deficits there. And then the last test is not done in physical therapy, but it's called caloric reflex testing. So you might see that from an ENT or an audiologist. They put cold or warm air or water into your ear, and then the warm side will be stimulated where the cold side will be inhibited. And that's going to cause rapid eye movements as a result. So based on everything we've discussed this far, it's clear the importance of incorporating balance as well into our testing with these individuals. There's a test I like to use called the balance error scoring system. You have them stand on level ground with their eyes closed. You have them stand on foam with their eyes closed. Okay, I got 4 minutes left. And then something else to consider is their autonomic function. Some people have what's called exertional intolerance. So when I'm trying to reintroduce them back to exercise, that might increase their symptoms. And they're not exactly sure what causes this, but it might be due to impaired autonomic function that is affecting the ability of the cerebral blood flow to the brain. And that might be due to damage to our autonomic centers of our brain, such as the hypothalamus. There's a Buffalo treadmill test that we use where basically you have them walk, and each minute you increase the incline on a treadmill, and you're trying to find out the point. You're assessing their vitals as you go on, and you're trying to find out a point at which they can exercise while maintaining pretty minimal symptoms. So we want to introduce individuals to a stepwise exertional program, beginning with activities such as stationary bikes before we do sport-specific drills and eventual return to practice. Athletes post-concussion have been shown to have a diminished walking speed when additional tasks are added on top. So I'll have them walk and I'll have them tell me colors, or we'll throw a ball back and forth, or we'll do all three of those things together. And if you think about sports, it's not just walking in a straight line. You need to be aware of your surroundings and the different things going on around you. So their decreased dual task ability may be responsible for an increased risk of musculoskeletal injuries that we see in individuals returning to sport following concussion. Other considerations that were unique in my treatment of this athlete was the fact that he was a collegiate student. So the general guidelines are to give them a few days of rest after onset. So if it was Saturday, I would do complete rest, maybe until Monday or Tuesday. And then I want to try to get them back to their daily activity as soon as possible, especially as a student. You don't want them to fall behind in their classes. So as a physical therapist, we're going to try to help modify things such as maybe the laptop screen brightness, have them work in smaller groups, can use sunglasses, those kinds of things, so they can get back to their classes. If they fall behind and their grades are poor, then by the time they're cleared from the concussion, they may not be able to participate in their sport anyway. This type of injury can have a significant impact on an individual's mood, as there may be a sense of anxiety and uncertainty as when symptoms will reside and when they'll be able to return to their daily activity in sport. Patient education is a critical component on our physical therapist end. We have to tell them, they're going to be fine. They might take a little bit longer than others, give them some general timelines, and kind of lay out what they can expect their recovery to look like. Other resources such as psychologists and sports psychology may prove to be beneficial in certain cases as well. So that was my experience working with a football player and getting him back to the classroom, which he was able to do after 8 weeks of physical therapy following his concussion onset. Thank you very much. If you guys have any questions, please let me know.